Top Med Talk.
Welcome to Top Med Talk. This piece is a question and answer session on the subject of perioperative care. It's hosted by Dave Selwyn, Deputy Medical Director at Nottingham University Hospital's NHS Trust and Director of the Centre for Perioperative Care. Also, co-chairing, we have Mike Grocott, Professor of Anaesthesia and Critical Care at the University of Southampton. On the panel, we have patient advocate Lawrence Mudford. He's enjoyed a 38-year healthcare career working as a dentist and dental educator within both primary and secondary care. Also, Stephen Evans, Centre for Perioperative Care Fellow and Anaesthetic Trainee, ST7. You'll also hear Sophie Randall, Director of the Patient Information Forum, and Scarlett McNally, Deputy Director for the Centre for Perioperative Care and Honorary Clinical Professor at Brighton and Sussex Medical School and Consultant Orthopedic Surgeon in East Sussex. We join them as they continue to take questions from the online audience. Don't forget, of course, part 1 of this piece is available in the show notes, as are previous parts of this meeting.
We're going to do some quick-fire questions.
Yeah, lots of questions, lots of interesting issues. Should coordinators of perioperative care be experienced nurses who we know show attention to detail, greater communication and recognition of need for help? That's probably a humble doctor, but maybe a proud nurse, I'm not sure.
I think it depends. I mean, I think communication skills, we're talking about communication skills here, aren't we? And I think there are things you can learn with communication skills. We've all got different kind of communication styles and preferences. I don't think it should, I think as we kind of heard this morning, I think it should be the preserve of everybody and every conversation to be having these discussions. So I don't necessarily think it's the preserve of nursing. I think it's for everybody to be involved in, fundamentally.
I would echo that, but I'm also interested in the GMC's decision-making document that came out, was it last year or the year before? Out of 7 points they make at the start, 4 are actually all about talking to patients and communication. And I think when you think about how old the profession is now, that's quite a damning, if I may say so, statement to have to put into a document on decision making, that they have to talk to people and have good communication. So I think we're a long way away, even for doctors and for surgeons and for anaesthetists. But yes, let's have the whole team on board.
And it's listening as well, isn't it? That's the other really important.
Apologies for cutting off, but we're quick. Yeah. There's so many questions that it's quick fire. So, Steve, this one's for you. How does the qualification fit in with those of us that have been practicing perioperative medicine for a long time, so the kind of grandfather, grandmother type clausing? And if you also could cover credentialing, is it a credential? Is it not a credential?
Yeah, well, I mean, this all needs unpicking of it. So a credential is, is a standalone, focused area of need. So I've used interchangeably credential, qualification, curriculum maybe. So I guess the idea is more of a formalised process, and we're taking a lot of our inspiration and knowledge from our ANSCA colleagues, really, because they're a few years ahead of us and are currently doing this at the moment. So we're watching very keenly to see what they do in Australia and New Zealand, how they do this and how it's implemented and how it fits in with postgraduate medical training and then subsequently with allied health professionals as well.
So I might build on that a little bit. So one of the key bits is to actually develop, to write, to specify the curriculum. That's the key first step. And in terms of that, what none of us want to do is to cut across the existing training that people have had, the existing aspects within the different specialties and curriculums, and say, actually, that's not part and parcel about it. This is not about adding masses. This is about lifting and helping to smooth that path. The aspects that then come on the back of the curriculum in terms of actually what you get at the end of when you've completed the curriculum, I think those are, to some degree, still up for some discussion. There is clearly a need that it needs to, or will need to, meet the needs of not just medical graduates, but also non-medical workforce as well. So there's quite a complexity there. I know we've got some people from Australia and New Zealand in the audience who've done some of the training. What comes of this at the end of it, I think, is still unclear. The reason partly I say that is that the GMC has paused the credentialing program, so it's put through a number of credentials and it's just paused, and we're just going to reflect on what those are delivering and how they're looking, and so we don't really have that clarity.
Well, how do you ensure patient collaboration involvement is not just tokenism and represents the majority and not the vocal minority?
I think it is. I think this is something that lot of our member organisations have struggled with, that, you know, you end up with white, middle-class, retired school teachers who want to be doing patient involvement. So it is actually about going out and finding people in different communities who want to take part and making that effort to go and find the people who really need to be involved. So it is doing that, and actually because some of these people might need support, they might means putting in some extra effort. Sometimes paying people for their time for some of this, or at least covering their expenses as well. And also when you're going around with those approaches, just make everything in really simple, plain English, so it's really clear and easy to understand, so people don't feel intimidated, because it can be quite intimidating. There's a power balance between patients and healthcare professionals a lot. So, or bring in somebody who's a community facilitator and a community leader who can help. But I think it is about making that effort and going out and finding the people you need.
It is. I don't think I can add much to that. It's an ongoing process, without a doubt.
And it should be a long-term relationship that you build, so you can go back.
I'm going to just read out, there's a handful of comments that all came through and have been well voted for, so I think they're clearly a reflection of the feeling in the room or online. So rather than who should, who can provide perioperative care across those care boundaries? All the superheroes are already busy. And another one, currently it seems like nurses are often firefighting and are overworked and under-resourced. How do we marry our aspirations with reality? There are a surprising number with that sort of tone in it. So briefly, it should pay for itself. I mean, a lot of hospitals experience shared decision-making in particular, and you do less surgery, you cause less long-term harm often. So any responses to that?
Sometimes it needs kind of a project to get started and some initial funding for people to realise that, because otherwise it's your last year's budget minus a bit, isn't it? Whatever, and fewer staff because so many people have stepped down. So it's a problem with workforce, and it's a problem with how things are funded. My thing with workforce is the registered professional staff should be doing the complex discussions, and that everybody else should be presenting information or signposting resources and encouraging people to have a different expectation and to go into that conversation with the senior nurse or senior practitioner or the doctor or the surgeon or whoever it is ready. So I think there's a split, and I'm hoping with all the work Steve's doing that once we've got this curriculum/credential to be the brilliant standard, we'll then take bits of it for other groups. So in the NHS, if you're any grade of staff, a porter, a healthcare assistant, can do the Making Every Contact Count training, for example, and that's really good, and it's an online training. You just put e-learning for health, and you can do it 2 afternoons or something online. They aren't shaming the person about something, but if a patient has a conversation with them, they're allowed to say, oh, I knew someone who quit smoking. I know there are some leaflets. Shall I go get you one? Rather than, yeah, it's tough, isn't it? I come out with my breaks here too. Kind of, it's just changing so that everybody's putting the right direction. But I think that difference between the registered professional staff and everyone else. I know in England they're trying to get care coordinators to follow people through the pathway. And we could have those as non-registered professional staff. There are quite a lot of people that want a job that are really good at communicating, but they need to be clear which bits are for the professional staff to deal with and which bits they can do as much as they can in their area. I think that's a big distinction.
Okay. Any more?
Yeah, there are absolutely loads. The link to primary care still seems missing. What are the plans for integration?
Oh, no, that is a tricky one. Go on, Scarlett. You want
No,
you don't want.
We don't want to overload GPs anymore, but they have got care navigators and paramedic practitioners and all sorts of people within primary care. But there isn't enough time for the GP in their consultation with the patient, in my opinion. Yeah. And I don't know how we fix that, so I'm trying to fix the bit that I think is fixable in secondary care, because we free up lots of time if we're not having complications. If people are going out the same day, if people have teed up to be ready and efficient, we're freeing up more time. So I don't know how it works in primary care, I'm sorry.
I guess one of your bugbears, Dave, is this context of refer back to GP. If someone's discharged from hospital, go see your GP for some blood tests. Just do them in hospital and have a look at them yourself. So
there are some opportunities within the changes that have happened at the beginning of this month in the NHS in England in terms of the establishment of integrated care systems or integrated care boards and trying to make that more joined up. And there are opportunities there to seamlessly help that. But I think we all recognise some of the difficulties that people have described, and GPs are swamped. We are working with some of the digital arms of NHS England about developing information that flows seamlessly between the primary and secondary care. So the actual information that comes into perioperative care referrals and clinics is stratified and isn't as onerous perhaps as some places are developing. And that should help engage, if you like, GPs. They will hopefully see some skin in the game for this. We have the College of GPs on our CPOC board, but they haven't got time to consider anything pretty much at the moment. So I think it's a very valid point. There is some work going on in Wales where they've taken some of the interface there and actually gone out and changed how GPs are working and referring those in with some success. We've got some case studies on the CPOC website around that.
How much is it going to cost and who's going to pay for it, Dave?
What? Everything.
Perioperative care.
This is where you make your bid, Dave.
Well, not much. So I think they are very. What I would start with is.
Do you want to comment on so Fiona speak last night, the pilots and the government engagement?
Yeah, what I would start with is that we have got record backlogs in this country, and at the moment the concept is to make everyone spin the wheel faster in the hope that that will cure it or address that, and that won't. We have to do things differently. There is no concept of us just continuing to provide or to address these backlogs by just saying, well, let's work harder. So that's the first thing. In terms of the working then differently, there's a whole host of things, but there's around 4% of you talked about the operations, about 4% of those operations that consume about 45% of the costs. So, and those are the people who get the significant complications, have a long length of stays, and obviously that's a huge group to target. There's obviously other aspects in terms of the high volume, low complexity, and there's other aspects in terms of actually can their care be provided in a different sort of environment or a different procedure. We're trying to get some pump priming funding, as Mike was alluding to set up a series of pilots or programs that show the benefit and show the savings and the costs. I think we've got good evidence that we can shave off length of stay on a number of different programs. A whole perioperative pathway will save about somewhere between 1 and 2 days on a complex patient. Some of the prehabilitation work will shave off of a length of stay. But putting it all together into a joined up pathway and doing proof of concept, I think, is still lacking. And that's the idea of getting these pilots funded. So that's what we're asking at the moment. And I had my begging bowl and cap out last night, asking various people for cash.
Can I also suggest that you ask patients to get involved in evaluating the impact, and it's not just about cost, because ultimately this is about treating people, isn't it, and the outcome for them, and I think that's really important. Cost is clearly important, but at the end of the day, it's about what happens to people.
Yeah, and that comes back to the people the 14 or 15% of people who say, actually, I wish I had an operation.
Yeah, absolutely.
Okay, we're running short on time, so this might be the last question. It's a good one. The biggest problem we have is that the decision to operate is already made at the MDT. Imagine if the patient was actually listening, watching, and contributing to the MDT. What do we think about that?
So I do tease my MDTs that the patient very rarely features actually in the MDT. It's not in the centre of the MDT, and they take that concept and say, do we need to get patients in? Is that what you're talking about? And I say, no, you actually don't consider what's right for the patient. So we have a neurosurgical MDT that goes through 100 patients in 90 minutes. That's a tick box exercise. There's no consideration there. That's a surgical planning. Yes, tick, do it. There's nothing about actually, is this a right operation for the patients, and are people considering what's important to that patient? I think that comes back to some of the points that Danny was making about actually, do we have any concept of what that patient values and thinks is important?
Can I just share one thing that we've heard from some of the people we've been working with? So Lawrence and I are both involved with the Professional Record Standards Body, and they have an About Me standard, which is going into digital records, or sometimes they're just paper things that people take into consultations. But where some of these people have used this, and they've been looked at by the clinician who's considering their shared decision-making conversation, it says it's completely changed the conversation. It's made it a more personalised conversation. They understand before they've even opened their mouth, some of the things that are important to them. And so that is changing that conversation. So I would just, I know PRSB is running a Care About Me campaign at the moment. But to me, it's been quite powerful hearing some of that testimony from people about how that they feel that's really changed the shape of those conversations. So I think when we've been talking about some of the difficulties about how you approach those shared decision-making conversations, if those are available, then I'd just say maybe use those. And if you can't get the patient into the MDT meeting, then if they've got that profile in the record, then have a look at that as well.
Scarlett?
Yeah, I really worry about MDTs because people think they're doing it properly because they talk that it's, one surgeon, one radiologist, one pathologist in a darkened room working out what cells are like and how much, what operation to do. Essentially, it's not really, because we've always thought of patients as single fixed problems, whereas there's multiple other complexities, and it's completely different for people with all those complexities. And I was talking about my mother had an operation last week. There was a multidisciplinary meeting about 5 years ago when they told her to have an operation, but she's got dementia. She wouldn't have understood. It wasn't causing her a problem at the time. And there was another multidisciplinary meeting about 4 months ago where they said she shouldn't have an operation, but without including her, without the surgeon who's going to do, without anyone in the room who knew the patient. So she turned up on the day it was cancelled. She just had her operation last week at a different unit. So it's kind of actually people think they're doing it, but they're doing it badly. I'm saying the story because people remember stories. So we need to educate the patients of what their expectations should be and information. But we also need to change what we think. And I think we need to get into other people's audit meetings, the radiology audit meeting. Why do you do it like that? Do you have the feedback from patients and things? The surgical audit meetings, clinical governance meetings. Why are those all siloed? It's just pathetic, really. But the key, I think, is those 14% of patients express regret, 10 to 15% of patients have a complication, many of which are preventable. Yeah. That's how to get the surgeons on board. And I'm sorry that surgeons are sometimes difficult to get on board.
Okay, we've run out of time. We've still got quite a few questions, but we've run out of time. So I'd just like to thank you all for your questions, your participation.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.